If you are over 60 and taking a blood pressure pill every single morning, there is a very good chance something is quietly happening inside your blood vessels right now that your doctor has never taken the time to explain. Not the medication working, not your body healing. Something else. A slow, predictable shift in the way your cardiovascular system is being managed day after day that can tip from perfectly controlled to seriously dangerous in a matter of hours. And the difference between staying safe and ending up in an emergency room often comes down to one thing: not how faithfully you take your pill, whether you actually understand what that pill is doing. I am Dr. William Lee, and for over 2 decades I have been working at the intersection of cardiovascular medicine and clinical nutrition, studying how the body responds to the most commonly prescribed drugs in America. Every single week, I sit across from seniors who have been taking Amlodipine, Lisinopril, or Losartan for years, sometimes for over a decade. And when I ask them what the medication does, what the real warning signs look like, and what everyday choices can make these drugs dangerous, the room goes quiet. Not because these are uneducated people, because nobody ever told them. Today that changes. Before we go further, I want to be direct about one thing. Everything I share in this video is for educational purposes only. It is not a replacement for the guidance of your personal physician. If anything I describe sounds familiar to your situation, please bring it to your doctor before making any changes to your medications. I cannot stress that enough. What I can do is give you the kind of clear, honest context that makes you a far more informed patient in that conversation. And if this kind of content is what you have been looking for, I want you to consider subscribing. I release a new evidence-based video every single week for people who want to understand their health, not just be handed a prescription and sent home. If that sounds like you, hit that subscribe button and turn on the notification bell so you never miss one. Now, let me tell you about Richard. Richard Haynes is a 77-year-old retired postal worker from Scottsdale, Arizona. For 31 years, he walked those routes in every kind of weather. He was proud of his legs, strong, reliable, the kind of legs that carried him through thousands of miles and 2 decades without a single sick day. When he retired, he kept walking every morning, 45 minutes before breakfast, a habit his wife Dorothy said was as much a part of him as his name. When his doctor added Amlodipine to his blood pressure regimen 3 years ago, Richard assumed it was routine, another tool in the toolbox. He filled the prescription, set his pill organizer, and went on with his life. 4 months later, Richard's daughter called him one morning and heard something unusual in his voice. He was short of breath after climbing his front steps. His ankles had swollen to the point where his favorite walking shoes would not close properly. By afternoon, his calves felt so heavy and full that he shortened his walks, then stopped them almost entirely. He told his son he was scared. He had started searching online for heart failure symptoms and was convinced something had gone wrong with his heart. His fear made complete sense, but the cause was something entirely different. And understanding the difference, understanding what amlodipine actually does inside your body, is the first and most important thing I want to teach you today. Amlodipine belongs to a family of medications called calcium channel blockers. Here is what that means in plain terms. Your arteries, the vessels that carry blood away from your heart, have smooth muscle woven into their walls. When calcium enters that muscle, it contracts. The vessel tightens. Blood pressure goes up. Amlodipine works by blocking the doorway calcium uses to enter that smooth muscle. With less contraction, the arterial walls relax, the vessel widens. Pressure comes down. Think of it like this. Imagine a garden hose with a clamp squeezing the middle. Water pressure builds up behind the clamp. Amlodipine loosens that clamp. The water flows more freely, and pressure drops. That is exactly what you want from a blood pressure medication. But here is where the problem starts for a meaningful percentage of people, and it is something almost nobody explains at the pharmacy counter. Your circulatory system is not one uniform tube. It has 2 distinct sides. Arteries carry blood down and out. Veins carry blood back up to the heart. Amlodipine is remarkably effective at relaxing the arterial side, but it has very little effect on the venous side. So, what happens? More blood is flowing into your lower legs through relaxed arteries. But the veins, which are responsible for pushing that blood back up against gravity, are not relaxing in the same way. You end up with an imbalance, more fluid arriving than leaving. Pressure builds in the tiny capillary vessels near your ankles, your feet, the space below your knees. Eventually, that pressure pushes fluid out of the vessels and into the surrounding tissue. The result is exactly what Richard experienced: ankles that look puffy by mid-afternoon, socks that leave deep marks in your skin, shoes that no longer fit, legs that feel heavy, full, and tired in a way that walking only makes worse. This is not heart failure starting. This is not a sign that your kidneys are failing or that fluid is building around your lungs. In the vast majority of cases, this is a predictable physiological response to how amlodipine works. The Cleveland Clinic has documented this as one of the most common side effects of the entire calcium channel blocker class, affecting roughly 1 in 4 patients to some degree. And here's the part that genuinely worries me. Not the swelling itself, but what people do when they see it. Some people immediately stop their amlodipine without telling anyone. Their blood pressure rises back up quietly, while they feel like they did the sensible thing. Others start cutting their water intake because they believe they are retaining fluid. That is exactly the wrong direction. And dehydration while on a calcium channel blocker carries its own serious risks, which we will cover in a few minutes. And some people like Richard, simply endure it in silence for months. They reduce their activity, assume the worst, and lose quality of life that they did not need to lose. The right response, the one I want you to remember, is a direct conversation with your prescribing doctor. Not because the drug is necessarily wrong for you, but because options exist that you may not know about. Elevating the legs, adjusting the dose, changing the timing, or in some cases, reconsidering whether a different medication in a different class fits your body better. Those are all legitimate paths, but none of them open if you suffer in silence or make changes on your own without guidance. Richard's swelling resolved within 3 weeks once his treatment was adjusted. He is walking his 45 minutes again. He told me last month that he wished someone had explained this at the very beginning. So I am explaining it to you now. If you have ever experienced that heavy, swollen feeling in your legs toward the end of the day while taking amlodipine, drop a comment below and let me know. You will be surprised how many people are quietly going through the same thing and have never connected it to their medication. Now, if this sounds too simple to work, I understand your skepticism, but the science is overwhelming and I am going to show you the data, because what I just described with amlodipine is only one of 3 completely different risk patterns that I want you to understand. And the second one is the most widely misidentified side effect in all of blood pressure medicine. Let us talk about Lisinopril. Lisinopril belongs to a class called ACE inhibitors, where amlodipine works on the muscle in your arterial walls. Lisinopril works on a biochemical pathway called the renin-angiotensin system. Think of this system like a series of chemical signals your body sends to tighten your blood vessels when it thinks blood pressure is too low. Lisinopril blocks a key enzyme in that signal chain, specifically the angiotensin-converting enzyme, which is where the name ACE inhibitor comes from. Less enzyme activity means less vessel tightening, which means lower blood pressure. The mechanism is elegant, and for most people, Lisinopril is a well-tolerated, highly effective medication. But it carries a signature side effect that is so common, so predictable, and yet so frequently misdiagnosed, that I have seen it disrupt people's lives for months and even years without anyone connecting the dots. The cough. Not a productive cough, not a wet cough, not the kind that loosens something in your chest. A dry, scratchy, relentless tickle at the back of your throat. The kind that is worse at night, that wakes you from sleep, that does not respond to cough drops, lozenges, antihistamines, or anything you can find at the drugstore. The kind that makes you sit up in bed for 20 minutes at 2 in the morning, wondering if you are getting sick. Here is what makes this particularly difficult to identify. The cough often does not begin immediately. Some people develop it within the first few days on Lisinopril. Others do not notice it until 3 or 4 months into treatment. By that point, the connection almost never crosses their mind. They have been on this medication for months without any issues. So, when the cough appears, they blame pollen season, dry air, their heating system, a cold that never fully cleared, or acid reflux. I want to introduce you to Dorothy Caldwell. Dorothy is a 69-year-old retired school librarian from Columbus, Ohio, an incredibly thorough woman who keeps detailed notes on everything she reads. When she developed a persistent cough about 4 months after starting Lisinopril, she assumed it was seasonal. It was late autumn. The heat had just come on in her house. The timing seemed logical. She tried 2 different antihistamines. She bought a humidifier. She scheduled a visit with her doctor, who ordered a chest x-ray that came back completely clear. 6 months after that initial x-ray, Dorothy was still coughing every single night. Her sleep was fragmented and exhausting. She was irritable, fatigued, and beginning to worry that something significant was being missed in her lungs. When she came to see me, one of the first questions I asked was very simple. When did you start Lisinopril, and when did the cough first appear? She pulled out her health notebook, which she keeps meticulously, and went quiet for a moment. She had started Lisinopril 11 months before our visit. The cough had appeared about 4.5 months in. She had never once made the connection. Once we identified the likely cause and coordinated with her primary care physician to transition her to Losartan, which works on a similar mechanism through a slightly different pathway and does not trigger this type of cough. Dorothy's tickle was gone within 10 days. 11 months of fractured sleep, 11 months of worry gone in under 2 weeks once someone simply connected the dots. Now, and this is the most important thing I will say in this entire section, I need to draw a very clear line. Because there is something else that can happen with ACE inhibitors that is not a nuisance. It is not a side effect you endure or manage. It is a medical emergency. If you are taking Lisinopril and you develop swelling of your lips, your tongue, the inside of your mouth, your throat, or your face, stop what you are doing. If that swelling makes swallowing feel unusual, if breathing feels even slightly restricted, you do not wait to see if it gets better. You do not take a Benadryl and lie down. You call emergency services immediately. This is called angioedema. It is uncommon, affecting a fraction of 1% of people on ACE inhibitors, but it can progress to complete airway closure faster than most people understand is possible. The ACE inhibitor pathway affects how your body manages a protein called bradykinin, and in certain individuals, that interference can cause rapid tissue swelling that has nothing to do with an allergy and does not behave like one. A dry cough at 2 in the morning is a conversation for your next appointment. Swelling of your throat is a call to 911. I need you to understand the distance between those 2 things. Please share that distinction with anyone you know who takes Lisinopril. Now, let us talk about Losartan, and let us talk about a danger that comes not from doing anything wrong, but from doing something that most people consider the healthiest possible choice. Losartan belongs to a class called ARBs, angiotensin receptor blockers. It works on the same renin-angiotensin system as Lisinopril, but instead of blocking the enzyme that creates angiotensin, it blocks the receptor that angiotensin binds to. Slightly different door in the same building. The clinical result is similar. Lower blood pressure with good tolerability, and without the ACE inhibitor cough that affected Dorothy. But Losartan and the entire ARB class have a consistent biochemical effect that becomes critically important depending on what else you are eating and taking. These medications tend to raise potassium levels in the blood. For most people, under normal dietary circumstances and with appropriate monitoring, that potassium stays in a safe range. Then add certain everyday choices and the picture changes completely. Potassium does not only come from bananas or potassium supplements at the pharmacy. It is hiding in a product that is actively marketed as the smart, heart-healthy choice. Salt substitutes. Many of the most popular low-sodium alternatives, the ones sitting right next to regular table salt in the grocery store, often labeled specifically for heart health or blood pressure management, work by replacing sodium with potassium chloride. So a senior who has been told, correctly, to reduce sodium in their diet, buys one of these substitutes and uses it generously on every meal. They are doing exactly what they believe their doctor recommended. And in the process, they are significantly loading potassium into their system while taking a medication that already raises potassium levels. When potassium climbs too high in the blood, it affects the electrical conduction system of your heart. This is not a minor concern. The heart relies on precise potassium balance to maintain its rhythm. When that balance is disrupted, the consequences can include muscle weakness, abnormal heart rhythms, and in severe cases, cardiac arrest. I want you to think about someone in your life right now who has switched to a salt substitute in the last year or two. If that person takes Losartan or Lisinopril, this is a conversation that needs to happen with their physician. Not because these medications are dangerous in isolation, not because potassium is bad for you, but because the combination, without awareness and without regular monitoring of blood electrolytes, can create a slow-building problem that never needed to exist. Electrolyte powders are another source that almost nobody considers. Many of the popular hydration supplements marketed to seniors, sold at pharmacies and health food stores as recovery drinks or daily hydration support, contain substantial amounts of potassium. They are not prescription products. Nobody thinks to mention them at an appointment, and that is exactly why they matter. Let me tell you about George Alvarez, a 72-year-old retired pharmacist from Indianapolis. Of all the people I might expect to catch this interaction, George had the background to understand it. But knowledge and habit are different things, and George had developed a daily routine that included a commercial electrolyte drink his neighbor had recommended for the summer heat. He was on Losartan for blood pressure and had been for 6 years without any problems. Over the course of about 3 months, George began noticing unusual fatigue that felt different from ordinary tiredness, a deep, muscular heaviness. Some weeks he felt occasional irregular heartbeats, brief fluttering moments that came and went. He attributed them to stress. It was his lab work, reviewed at a routine appointment, that revealed his potassium was at a level that required immediate management. The combination of his medication, the electrolyte drink, and a habit of using a potassium-based salt substitute at every meal had quietly pushed his levels into a dangerous range. Once the contributing factors were identified and his diet and supplementation adjusted, his potassium normalized within weeks. But the window between where his levels were and a serious cardiac event was narrower than anyone would have wanted. Now, while that first approach works, here is a variation that works even better for people in your situation. And it involves understanding what happens to these 3 medications when your body is under stress. Not serious stress. Not hospitalization. I mean the ordinary kind that happens several times a year to almost everyone. A stomach virus that leaves you vomiting for 2 days. A summer heat wave where you are sweating more than usual and not drinking enough water. A few days of diarrhea that drains your body's fluid reserves faster than you realize. Most people think of their blood pressure medications as constant. Same pill, same dose, same effect every day. And under normal circumstances, that consistency is exactly what you want. But your medication does not operate in a vacuum. It operates in the context of your body's internal environment. And when dehydration shifts that environment, the same dose of Lisinopril or Losartan that was perfectly calibrated yesterday can behave in a dramatically different way today. Here is the mechanism. Both ACE inhibitors and ARBs influence how your kidneys handle fluid. Your kidneys are constantly filtering your blood, adjusting fluid levels, and maintaining blood pressure from their end of the equation. When you are dehydrated, your kidneys are already working harder to conserve every drop of water they can. Now, add a medication that alters the hormonal signals those kidneys rely on. And you have created a situation where blood pressure can fall too low, too quickly, and where the kidneys themselves become vulnerable to injury. This is not theoretical. Acute kidney injury related to dehydration, combined with ACE inhibitors or ARBs, is well documented in clinical medicine. The Cleveland Clinic considers illness-related dehydration one of the most underappreciated risk factors for patients on these medication classes. And yet, when I ask patients whether their doctor has ever given them a sick day plan for what to do with their blood pressure medication, the answer is almost always no. Here is the plan you should have, and if you do not, this is the exact conversation to have at your next appointment. Ask your doctor directly. If I develop a stomach virus, if I cannot keep fluids down for more than 24 hours, if I am experiencing significant diarrhea, what should I do with my Lisinopril or Losartan? Should I hold a dose? At what point should I call the office? What symptoms should send me to an emergency room? Those are specific answerable questions. And having the answers before you need them is the difference between a safe recovery at home and an avoidable crisis. Quick question before we continue. Has your doctor ever given you a sick day protocol for your blood pressure medications? Drop a yes or a no in the comments. I have a feeling I already know what most of you are going to say. Now, I want to address something that creates a specific and preventable danger for a large number of seniors managing blood pressure with any of these 3 medications. It involves a product that almost everyone over 60 has used at some point. Something available at any pharmacy, any grocery store, no prescription required. Ibuprofen, naproxen, the over-the-counter anti-inflammatory medications that most people reach for without a second thought when arthritis flares, when a knee aches, when a back goes stiff after a long day. Your kidneys do not read labels. They do not distinguish between a prescription drug and something from the drugstore shelf. They respond to chemistry. And the chemistry of non-steroidal anti-inflammatory medications, what doctors call NSAIDs, interacts directly with the same biochemical pathways that Lisinopril and Losartan are working on. When you take NSAIDs regularly alongside these blood pressure medications, especially in the context of any mild dehydration, you can meaningfully reduce blood flow to the kidneys. Over time, this combination creates real risk for kidney function. It is one of the most common, most preventable situations I encounter. And the reason it keeps happening is the same reason it is so dangerous. People do not think of ibuprofen as a medication in the same category as their blood pressure drugs. It is just something from the drugstore, something for the pain. If you regularly use ibuprofen or naproxen for joint pain or back pain, and you take any of the 3 medications we discussed today, please have this conversation with your doctor at your next appointment. There are often safer alternatives, including acetaminophen, topical anti-inflammatory creams, physical therapy approaches, or, in some cases, adjustments to your overall treatment plan. You do not have to simply accept the pain, and you do not have to silently accept the risk. Let me pull all of this together for you, because I want you to walk away today with a crystal clear action plan. There is one more thing I need to address before we get to that. Dizziness, that brief tilting sensation when you stand up from a chair or get out of bed. The world goes slightly sideways for 2 or 3 seconds. You grab the door frame, then it passes. Many of my patients tell me they experience this regularly and have never mentioned it to their doctor because it seems too minor to bring up. I need you to hear this clearly. In an older adult, a few seconds of dizziness is physically sufficient to cause a fall. A fall is sufficient to cause a fracture, and a hip fracture in a senior can alter the entire trajectory of the next several years of their life. The dizziness itself is not the threat. The fall it enables is. What is happening physiologically is this. Your blood pressure medications lower your blood pressure. When you stand up suddenly, your cardiovascular system needs a moment to redirect blood flow upward against gravity. If the adjustment does not happen fast enough, pressure briefly drops, blood flow to the brain momentarily decreases, and you feel it as that familiar lightheaded tilt. The practical fix is often very simple. Rise slowly. Sit on the edge of the bed for 15 to 20 seconds before standing. Hold something stable when you get up. Give your body those few extra seconds to catch up with the change in position. But if dizziness is happening regularly, if it is occurring every morning or after every time you sit down and stand, or if you have ever had a moment that felt like near fainting, those are symptoms that deserve a real medical conversation. The dose, the timing, the specific combination of medications you are taking, or your hydration habits may need adjustment. I also want to spend a moment on something that creates unnecessary anxiety and sometimes genuinely dangerous impulsive decisions. Home blood pressure monitoring. Monitoring at home is valuable, but I see a pattern over and over again where someone checks their blood pressure at what turns out to be a difficult moment. The number looks high, and they react with panic or extra medication or a frantic call to the office about a reading that, in context, was completely unremarkable. Blood pressure is not a fixed number. It fluctuates throughout the day in response to caffeine, pain levels, emotional state, whether you spoke or moved right before sitting down, even whether you are anxious about the reading itself. A single elevated number on a random Tuesday morning means very little on its own. What matters is the pattern, the same arm, the same time of day, after 5 full minutes of quiet rest without talking or moving. Track those readings over several days. Bring the log to your appointment. Let patterns guide the conversation, not individual numbers. That shift alone will reduce a significant amount of unnecessary anxiety and will give your doctor far more actionable information than a screenshot of one alarming reading from your home monitor. If you have made it this far and this video has given you information you genuinely needed, I want to ask you to do 3 things before you leave. First, drop a comment telling me which of these 3 medications you are currently taking and whether anything I explained today connected with something you have been experiencing. I read every single comment and I respond when I can. Second, hit the subscribe button if you are not already subscribed. Everything I share here is built on the same principle we use today. Real explanations, not just instructions, but the reason behind them. And third, share this video with someone you care about who is on blood pressure medication. They may have been quietly dealing with something they did not understand, and this conversation might be exactly what they needed to hear. Your body is not failing you. These medications are, in most cases, doing exactly what they are supposed to do. The problem is that they work inside systems that are affected by dozens of everyday decisions you make without realizing the connection. Your fluid intake on a hot day, the salt substitute in your kitchen, the ibuprofen you take for your knee, the way you stand up in the morning, these things matter. And now you know why. Richard Haynes is still walking his 45 minutes every morning. He just does it in a new pair of shoes that fit properly. Dorothy Caldwell sleeps through the night again. George Alvarez manages his potassium carefully and checks his labs every 3 months. These are not dramatic stories of miraculous recovery. They are stories of people who got the right information at the right time and used it. Keep going. Your body is more resilient than you think.